Join me, Charlotte Stallworth, Vice President of Business Development and Innovation at Stanford Medicine Children's Health, as we engage the brilliant minds driving change in healthcare, unraveling the mystery behind the next medical innovation. Hi, everyone, and welcome back. I'm so pleased to have you join us today for our topic on how gamification can be beneficial to healthcare. And our guest is Dr. Dennis Wall, a Stanford University professor, and he runs a pediatric innovation lab dedicated to leveraging biomedical informatics to unravel the complexities of childhood-originated conditions, notably autism and related developmental delays. Pioneering machine learning and artificial intelligence, Dr. Wall has revolutionized the detection of neurodevelopmental disorders in children and introduced innovative applications such as wearable devices for real-time therapy. His groundbreaking work has earned him recognition as one of the world's top 25 autism researchers, and he was named as one of the top 50 healthcare innovators by Fierce Health. Amazing. And I'm so pleased to welcome you here, Dennis. Thanks for joining us. And I'll just dive in with the first question. What inspired you to integrate gamification into diagnosing and treating autism spectrum disorder?
Well, the first simple answer is that kids love games. But we went on, we wanted to create a naturalistic experience for children that would scale, that would reach the families in their home, in their natural environments, and be something that they could access at any time during the day and would want to access it because it would be something that is fun and engaging and at the same time quietly helpful and interventional and therapeutic. So that's how we sort of got started. And I can go more into the story if you want, but I have a couple ways of also answering it around why wearables and then ultimately why phones and tablets.
Yeah, definitely. I think appreciate how gamifying anything can make it more engaging, and definitely for kids. I would love to hear about some of the technologies you're using to implement those games. So yeah, you want to talk about wearables here
Yeah,
now?
absolutely.
Yes.
We got started. I should say we had done a lot of work on diagnostics. We'd done a lot of work on trying to utilize ubiquitous technologies, in this case, phones and applications, native applications on phones, to capture whole child data in a very rapid and scalable way that would enable the detection of autism as distinct from some other developmental condition as young as 18 months, definitely by 36 months of age. And we were really successful, and that leveraged machine learning and artificial intelligence and techniques in computer vision. And we were successful in that regard, and go more into that if you'd like. But then it dawned on us that I should step back and say, there is a global health crisis with respect to detection and treatment of children with developmental concerns, including principally autism, but also many other things like ADHD. There's a wait list to get access to a diagnostic evaluation. That's 18 months on average across the US. And then once you get a diagnostic evaluation, there's a wait list to access therapies. That can be equally as long, a year and a half, potentially 2 years. And so families may not get served until they're beyond windows of brain development where the impact of the therapy is most potent. And so it cries out for help. How do we help how do we alleviate these bottlenecks? And when we finished this journey of creating something for diagnosing, we needed to pivot quickly to creating something for therapy because we didn't want to create even more children in need on the waiting list, waiting for access to therapies. And so we needed to innovate there. And so in 2014, roughly 2015, in that time frame, my lab focused heavily on on moving from diagnosis to therapeutics. And at that time, Google Glass was a thing. It was like a phenom. Everybody had a pair for a hot minute. This augmented reality form factor that Google invented was revolutionary. And there was this notion that people were going to buy them and wear them and read their emails while they were riding their bikes and stuff like that. But but it turns out that wasn't the case, and so it fell flat on its face as a direct to consumer device. But it was perfect for bench to bedside, for medical applications, for applications in the field. For example, pulling up blueprints or electrical wiring diagrams and stuff like that. And then suddenly it dawned on us, well, we could actually use this to create an experience for a child that's gamified and that really informs them about their social world. What is the most potent and important ingredient for autism therapeutics, especially at the early windows of development, is to take a child who would normally focus on asocial and have that child focus on social. Look at faces, understand the variation in human emotion, make more eye contact, and begin to find human face and face expressions informative and exciting, to create that curiosity for social behavior as opposed to a curiosity for something that might be regressive and that would further isolate the child from their social experience and cause the need for lifelong care.
Right.
If you intervene before 6, you intervene with teaching children how to make more eye contact, how to understand emotion, expression, variation, and many other things like that before they're 6, they become better in the sense that they can integrate into mainstream schools, they can participate in classrooms and thrive on their own. And so the wearable was a great way to do that. And why? Because the children are wearing the glasses, and that outward facing camera is capturing their world and telling them in real time, that's a happy face, that's a sad face, that's a surprised face. And it's coming in the form through the prism, this heads up display that was embodied in the Google Glass wearable itself, a very lightweight, audible at the line of scrimmage, to take an NFL analogy.
I get it. I understand that.
Or, Jiminy Cricket on your shoulder, simply saying happy, sad, surprised. And also saying, good job, you found a face. Now let's see what that face is telling you. And you can create these games like Capture the Smile, where the child's job is to run around the room and get mom to laugh, or to make a disgusted face because you make some silly joke about something that I won't say here. You get the idea, and it creates
Yes.
this energy of excitement around that social interaction. And what's exciting about this too, I'm sorry I'm talking too much, but it's like capturing data while it's treating the child. So the wearable was good at creating a dynamic feedback, see the world, report back on the world. But the actual software on the capabilities of the hardware and the software inside the Google Glass was not sufficient to run our computer vision models, and so we had to use it as as just a transmission system. Take it in, send it to a phone, have the phone process, have the phone then submit in real time back what the feedback should be for the child. So the phone is capturing and restoring all of that video feed throughout the experience of the game, the Capture the Smile game, for example, or Guess the Emotion game. And those video clips become rich libraries of information about that child's social experience that you can use to create a more holistic type of therapy to review at the end of the day. Here's the time where you didn't realize I switched from happy to sad or anger because you kicked your sister, that sort of thing, and reinforce the learning, but also capture this new computer vision data that we can then leverage in ways that we were able to do in the subsequent iterations of the Glass project. Unfortunately, Glass failed and they stopped manufacturing, but it was a great experience. And I think there'll be other augmented reality form factors that we could take advantage of that would have the same impact. I should say the impact, by the way. I'm talking way too much. I'm sorry. I've had a lot of
It's fine.
The impact was we could see the same gain that you'd get in 2 years of treatment using standard of care type techniques within a period of 6 weeks of using Google Glass, our augmented autism glass therapy. So in a very short time frame relative to what you need normally, you could get the same change, positive in this case, change on an endpoint that the FDA, for example, cares about to show the efficacy of this device, and that it's very short window, 6 weeks versus 2 years.
Wow, I love that. And you've said a lot and I appreciate that. This is really exciting work and I do understand how, innovation leads to more innovation. And I love your example of Google Glass. Maybe it had, the thought was use cases would be different from what it was actually used for. But it was amazing that you were able to take that device and that innovation and use it to innovate, the diagnosis and gamification kind of modifying behaviors for kids who would benefit from it. So I think that's really exciting and love your examples and kind of the natural journey of this created by synergies, right? And development of how you're moving forward. So can you tell us about some of the challenges or gaps in and starting back a little bit with the diagnostics and then moving to the behavior modification work, but gaps in the traditional diagnostic methods that motivated you to explore gamification and these innovative solutions for developmental disorders?
Absolutely. Well, the reality in the field for autism in particular is that, and this is pretty much true for every other developmental condition, is that there really isn't a standard of care. There hasn't been a standard of care. There are research instruments that have been repurposed for use in clinical settings, and they're used haphazardly, or I should say, in a way that's very heterogeneous. It's sort of choose your own options. There are 30 or so instruments out there that are used in clinical practice to support the diagnostic evaluation for a child who's at risk for an autism diagnosis. And so it becomes like a 30 choose 2, choose 3 type of factorial problem. You're getting this variation in utilization. There are a few that are preferred, one of them being the Autism Diagnostic Observation Schedule. However, that one, which is written into medical policies in some places for states' coverage of Medicaid support for therapies like the one I just described. But that instrument, that research instrument, while one that can provide a very rich picture of the child that supports the diagnosis, is done in clinics by clinicians who must be trained, and they're far outnumbered by the number of kids, who need to be seen. And so it stands at in the very neck as a cork of the bottle and gates access to the diagnostic evaluation. Not to mention the fact that it's very lengthy. It can take hours to complete and administer. And even after that, it's very subjective. I've seen clinicians perform the test, score the child, get an outcome, and then just disagree with it, empirically, and go back and erase some of the numbers, change them to get an autism diagnosis.
Wow.
And it was there. In fact, I was professor at Harvard at the time training on this system. And it was then that it dawned on me that this needs to change, that we have to infuse quantitative thinking and data-driven approaches into the field to create something that's objective and scalable. And so that's where we went with our mission to create a machine learning assisted, I should say, not entirely artificial intelligence, but one that has humans in the loop at certain stages to be able to provide a robust and scalable diagnostic solution that would open up access, that would provide a definitive and very trustable outcome that can be used, that's diagnostically valid, clinically valid, that's numerical, and that can be repeated, and it's remeasured and objectified, all of those things that were needed to make this a medical device, as opposed to just a haphazard solution that's used for repurposing research instruments and things like that has been done up until now. Now we have something that's truly a medical device, FDA authorized, FDA cleared, and so forth.
That's really exciting. So an FDA cleared device that's based on machine learning and quantitative data to really give a diagnosis of autism in kids if it's appropriate. And I assume with that machine learning, that's kind of a cool thing in artificial intelligence that we're all in the space of innovation are thinking about these days. Of course, that data, it's important to have a kind of a variety of data supporting that kind of machine learning. Could you speak to that a little bit, especially as we consider, equity in healthcare, reducing disparities, and ensuring that all children are diagnosed and, viewed, in the appropriate manner?
Right, right. So this is why artificial intelligence or machine learning models are so valuable, so powerful in these contexts. It's because you can train, if you have the data, you can train the models using more cases and a diversity of cases than any clinician can see in their lifetime. You can create a model that, in fact, can see more cases than many clinicians can see in their lifetime. And that's exactly what we did. And we made sure to infuse that model's training set with the diversity of samples that would reflect the general population of the United States, certainly, but of the world, really. In this case, this would include underserved populations that have historically not been diagnosed. Now, these research instruments that I mentioned previously have known biases. They are known to miss females. They are known to miss Black American. They are known to miss Hispanic populations. They've been tested and shown that that's true. And fixing it is not an easy problem without using great training samples that represent the population diversity that's out there. And so we worked really hard. In fact, it took about 8 years to collect enough of the information necessary to be able to train the model so that it would perform equitably across age ranges, here in this case ranging from as young as 18 months to much older, but certainly before 6 is where we really want to be, before 72 months, but also females and every other population we could think of including indigenous populations in the United States.
I definitely appreciate that approach. I think it should be somehow a requirement to consider kind of fairness and diversity when we're creating new innovations, especially in healthcare, but across our nation and the world. I think even for law enforcement, I don't know, beauty tips, all of those things, I think all needs, diverse information to inform the users so everyone gets a high level experience. So definitely appreciate the work you're doing there. And really, one of the things I look for is how we can incentivize or encourage others to do that work early on in the development of new innovations versus creating something, launching it, and then saying, oh, by the way, you need to look for any bias or something that may result from this device.
Right.
So really appreciate that investment you made of the time to ensure you have a very a tool that can be used equitably across the population of children who really need it.
Yeah.
So can you give some other examples of the gamification tools you've implemented, and maybe how
Yes,
some of these games have transformed the traditional approach to diagnosing and treating disorders?
absolutely. So when we finished our trials for Google Glass, which we ran several, and one in particular was really a pivotal kind of study where we used a randomized structure with an intent to treat protocol that was quite robust and unique in the field, actually. And that was published in JAMA, showing this efficacy that I mentioned. We felt like, okay, this is, if Google Glass continues to have a life, this is actually something that should translate and be turned into a product that the world can get. Unfortunately, Google Glass died, but before it died, thinking it was all good, we transitioned. I always worried about the wearable. Like sometimes
Yeah.
kids have sensory issues and they don't want to wear the glasses. And so we needed to create another tool in the toolbox. And I was playing with my kids this game called Heads Up, where you put the, I don't know if this is going to show up here. You put the
I
phone
can
on your
see it. Yes.
forehead and it shows a prompt on the screen, and it's a form of mobile charade. So I'd play it, and it would, the word lemur would be on the screen, and my kid would try to figure out how to act like a lemur. It's very, very fun. And it's popularized, created and popularized by Ellen DeGeneres, and it's like a widespread, really fun game that people play all over the place. It dawned on me that if we turn the camera on and show the child, meaning the outward facing camera that you can get here, that one,
Right.
and and uh, and show the child the developmental and age appropriate prompts and challenges, you could intervene in very similar ways to the ways in which we're intervening with class, meaning teaching emotion recognition, teaching increased social motivation for eye contact, socially appropriate eye contact, understanding that variation in human face, not only seeing it in mom, but being able to express it oneself. That expression or imitation is even a better indicator, more physiological indicator of that child's understanding of the difference between a happy and a sad and a surprise kind of emotion. And since you turn the camera on, you're capturing this child's experience. You're capturing the child in a way that enables you to measure progress and understanding. And those are key ingredients to us being able to change the game in ways that are progressing the child from an earlier version or the first phases of the education that we're trying to deliver to the child. And as they advance, increase the challenges and the complexity of the training and education that the child receives, so that they progress to a point where they no longer need to play the game and can, go on their own and play with their peers from there on out. So anyways, that game we were trying to think of a name for it, and it was I wanted to call it Heads Up, but that's so we called it Guess What?
Okay.
And then began to develop it together with some colleagues here at Stanford who do clinical care for children with autism, to make sure that the ingredients of the game were reflective of the naturalistic behavioral interventions that they know are most effective for children across the diversity of range of age and developmental abilities that we wanted to address. So I'll stop there for a second and see if that's enough of an answer, but I can go on.
That is a wonderful answer, and I appreciate the completeness of it and kind of the arc, and kind of also how you ended there, and kind of touching on the, speaking with people who are clinicians who are working with kids with autism to ensure that what your game is effective, right? And doing those studies and taking the time to do that. I think that's really important and part of the advantage of academic healthcare and innovation. So can you tell us a little bit more about how the games enhance the therapeutic process? I can see that it's engaging for the child. So even that is a big step, right? Getting the child to be engaged in the game that helps them to engage in the therapy and to progress. Maybe a little bit about the age ranges. You talked about diagnosing early and intervening early, and then maybe some of these games are geared toward the older kids. So can you kind of talk about how that kind of changes, your approach changes with the kids' progression?
Right. That's a great question. Initially, as a form of mobile charades, the younger kids, 18, even up to 24 months, are not going to be as responsive. So, and so initially we were designing the game for 3 to 12 or 3 to 8, where the windows are still very potent. There's still great opportunities, of course, to intervene and provide the interventional ingredients that are very successful, so that by 6, when they enter kindergarten, roughly, they're able to do so with very little support, with maybe a modest amount of an IEP, but otherwise they're essentially mainstream. And this is true, by the way, for 4 in 10 at least. 4 out of 10 children who, if treated properly before age 6, will progress to a point where they no longer qualify for an autism diagnosis. That's like 37,
Wow.
38%. And these are numbers that were recently published by a great study done at Boston Children's Hospital by colleagues of mine, showing this. And we've known this for a long while, but it hasn't been properly documented in the way that the Boston Children's Hospital did document it. And so now we've got these great empirical findings that support our empirical understanding that if you treat these kids before these windows close, you will get a lot of gain, and that gain can lead to eliminating the autism diagnosis. Anyways, so I digress here for a second to say there's still a great window of opportunity if you're starting at 3 and treating until 5 or 6. However, there is this missing window. There's still, if we can diagnose at 18, what are you gonna do? If you diagnose at 24 months, we started to build toddler decks, essentially, that would provide age appropriate, counting experiences, or experiences where the child is watching some sort of story play out on the screen with marine animals or with bubbles or other things like this. And so the other, I guess, cool thing about these games is that as a native application on an iOS or an Android device, and we work really hard to make sure that these games work on Android devices of a high variety so that we can reach a diversity of populations out there, including lower socioeconomic groups. We can change the games continuously. We can create new decks, new challenges overnight and push those changes to the game. If we decide, we really need to infuse this new toddler feature where the child's challenges are going to be about, Thomas the Tank Engine or something like that, we can do that. And of course, we might violate copyright, so we have to be careful about that one. But other things like that, we can simply infuse overnight, and we can create this pluripotent system that changes as is necessary, essentially. And then once they get to that level where they can start to do mobile charades, here in this case with emojis or emoticons or with cartoon characters like the ones behind me, showing a range of ways in which they may express happy, then they can start to engage in those mobile charade types of experiences.
So let's see. So what you've kind of touched on this a bit just now, but what are some of the other unique benefits that gamification brings to maybe diagnosing and treating developmental disorders that traditional methods may not offer?
The one is a variation. There's gamifying things opens up inventive opportunities where you can create and they can create. Like all of a sudden, you can create in our cases, we do this with children. They can choose and they can create their own rewards, for example.
Oh.
Like the kinds of things they can earn as a consequence of leveling up, in the game. And this includes characters that they can put into their wallets or whatever you want to call it, or coins they can put into their wallets. Whatever incentivizes them, they can make it and use it and leverage it as they advance through the game. And how do they advance? Well, they have to get a certain number of correct guesses. They have to match a certain number of emotions. They have to remember a certain series of face challenges, or have to be able to express a number of different words within a certain time frame. Some of the variation that we have within the Guess What game, for example, that's not just focusing on image recognition and emotion recognition or imitation, but also focusing on prosody, tone, and recollection. So, like, tell me how many, name as many animals as you can within 90 seconds. That sort of thing. Name as many animals as you can that live in an ocean, or that live on a farm, or that are on safari with you. Those kinds of challenges get the child to think, recollect, and express, and we hear their voice, and we can use that information in ways that we as clinicians or as clinical inventors can that we can use to see if there's change that's positive or not, and make changes along the way to make sure the child's receiving the right periodicity and strength or dose of treatment. But I should come back to the answer to your question specifically, is that gamification just creates this endless, appropriate sea of opportunities for creation that's going to be very personalized to that child's desires and that child's motivation, and therefore also likely to be something that's going to be more powerful for that specific child.
I can see that. And, I was going to ask you about how the gamification creates that personalized experience, which you're already saying, right? Because the child is able to create or select their own incentives, which encourage them to engage further and longer in the activities, hopefully leading to better outcomes, right? So
Right.
I think that's really compelling, because sometimes when you think of personalized tools or personalized medicine, it seems very expensive and far away, right? And this seems very accessible and easy if you're just thinking about it in the right way. Could you just speak about it a little bit more about how that personalized experience? I mean, it's interesting to me, personalized is like the individual, but you're trying to reach a huge population of kids. So there has to be a way where that game is launched or the experience is launched and still um, impacts the child as they grow. So do you just provide additional games as, I guess, can you kind of describe the child's experience, maybe using these games at home, going back to see their physician, and how the physician then maybe, I don't know, prescribes something different?
Yes. So the way that we structured Guess What was similar to the way we did Glass, and this was designed to be used 3 times a week, 3 times a day, spread across the week for 4 to 6 weeks. So like Monday, Wednesday, Friday, 3 times a day. And each game is about 90 seconds in length, although you can play many different types of games. That's the minimum, we'll call it the minimally viable dose that we empirically believed would be most efficacious. And then we went on to test it, and it turns out that that is true. What do you do in those sessions? There's a requirement to use our emotion recognition decks. And so these are emojis, emoticons. We also have a bunch of GIF images that we were able to repurpose from TikTok, actually, where TikTok had done an emotion challenge and created a kind of an organic and viral, TikTok challenge, whatever the typical TikTok challenge, where a bunch of adolescents and adults, young adults, pick it up and do the challenge, and creates this huge diversity of expressions that are live, and you see them on the screen, really popping out at you. Anyway, so those are required so that they do get that valuable ingredient of the naturalistic behavioral intervention, teaching them not only that human faces are interesting and worth looking at, but also that they vary, and how they vary is informative to what's going on inside that person's mind. And like, it teaches you how to read people's minds in ways that you couldn't before. And so we do that, and it's gamified in the sense that you can choose among that huge diversity of image data what you want. And so we believe it's big enough that it's going to match any particular child's desire, whether they want to see cartoon characters or human faces or certain types of human faces or GIFs or static images, all sorts of things like that. So those variations are there for them to choose, but they must choose that emotion experience as one of the games. But then they can go off and choose a dance deck, a safari deck, a sing-along kind of deck. And we're starting to bring in generative models. Not surprisingly, all the rest of the world here is using things like ChatGPT. It turns out that these transformers are really, really good. They can hallucinate, certainly, but when you canalize or bound them, circumscribe them within a space that's appropriate for a 4-year-old, like a short 500 word or less fairy tale where it's like reading to you aloud, but also showing you images of the fairy tale as it goes. So Jack and Jill went up the blank, and you have to fill in the blank.
Okay.
And you create this on the fly. In fact, we can let children create them on the fly, so that they create their own type of fairy tale that includes what they care about, and they may care most about Spider-Man or about Wonder Woman at that moment in their development, or another kind of character, and they can choose that character and create that fairy tale. It's bounded though, so it's only a certain number of words where there's a certain number of missing pieces, and they have to fill in the blanks. And by them filling in the blanks, we get them to so we understand their recognition, we understand their ability to, um, to actually perform the task, in this case, to fill in that blank when appropriate. Hopefully I'm
So,
answering your question, but
yeah,
that,
it
that,
does.
that, as long as we have a baseline of we have a minimally viable dosing program, we know we are infusing these naturalistic, and then we're adding on top of that these gamified experiences that they can choose, which we use in ways to get more data, we use in ways to understand the child's progression, and we can use in ways to build new models in the future that will increase our ability to phenotype that child, measure their cognitive capabilities at any given time, and react accordingly.
I love that, where you're improving what you provide to the child based on data from the child, but also providing data for other children. So I love the way that you're discussing that. I wanted to ask a little bit more about how you see the emotion recognition technology evolving and impacting the broader field of behavioral analysis and mental health diagnosis.
Good question. Initially, when we got started, the off-the-shelf emotion recognition classifiers you can get from, for example, Amazon or Microsoft or Google were exceedingly bad at understanding variation in children. So really good at adults, but terrible at children. Why? Because the training data didn't exist. There was simply no good sets of training data. One small one called Cafe that existed. And so it created this urgent need for us to have to create our own training library. And as I've just described, guess what? You can imagine, since we're turning the camera on and we're asking the children to practice emotion through imitation, we're suddenly gathering and building this incredibly powerful training library of diversity of children. So now we've pushed, guess what, of course, live free out there in the world as an app anybody can get. And it's been used by most countries, by children on and off the spectrum across the world. And so, and many of them share willingly. We can get into the question of trust and share and security and privacy in a second, but it's sort of leaving that out for a moment. Because the game is fun and engaging, when they're asked at the end of the game, do you want to share your video library with us? Many just say yes, which for us was quite exciting because it enabled us to create this training library. And what's really exciting too about that is the moment in time where the surprise face is being shown to the child. So on the phone, we'll have a surprise face will be on the screen, and the job of the child is to recognize surprise and act surprised. And if we even use a weak classifier, a weak model on the frames of video data that are in that time window between the prompt getting shown and the prompt, changing to a different prompt, we can find the appropriate images of the child beginning to form the surprise face and actually performing the surprise face, and then use that information to populate our training libraries.
Okay.
And so suddenly we have this training library of surprise and fear and disgust, and that's for the Ekman emotions. And you may be wondering, how do you deal with more complex emotions? In the same way. And we don't have great classifier until we've created these training libraries. We did not have the ability to create classifiers for children who are making more complicated faces, like interested, confused, flirting. I don't know how many children flirt, but you get these more complicated emotions.
Right.
You suddenly can actually build a training library and build a model, therefore, that will differentiate those more advanced human emotions.
Thanks for sharing that. Can you tell me, I know there are a lot of people working in this space and kind of related spaces. Can you tell us a little bit about how you envision or how you actually do collaborate with other researchers and clinicians to develop gamified healthcare solutions, and maybe AI machine learning models for autism spectrum disorder or other diagnoses?
Yes. So we've, we obviously we go to conferences and present and share our data with our colleagues out there so that they can take advantage of these training libraries that we've built any chance we can. This is of course given the data use agreements
Yeah.
and things like that. But so we do that. We also so we go our my team, my lab is transdisciplinary and includes students from computer science, mechanical engineering, electrical engineering, as well as biomedical data science. And it's and I should say also students who are in the Graduate School of Education at Stanford, students who are coming at this from a very, from very unique training backgrounds with different skill sets. And it's that enables us, and it's really through the students that we can begin to collaborate with professors who are doing education, professors who are doing computer vision for this, just purely computer vision in this case, building interesting new mathematical approaches and other kinds of approaches to um, artificial intelligence, engineers who are actually building devices, or in this case, building systems that will embed within and take advantage of sensors in native, on phones or in apps on phones, these sorts of things, so that we can bring all those different ingredients together in ways that enable us to build something that's going to translate as a product for widespread adoption in a setting where it can get access, it can get to all the kids who need it. This could take the form likely of a company, taking it forward and scaling it appropriately, potentially Google, since this is a Google supported podcast. um, so we are collaborating with our colleagues in that way across the 7 schools, most of the 7 schools anyways, here at Stanford. But then also, with those edges, in our little network, we start to then reach other universities and share our ideas there as well. So there are innovators coming up who are doing just emotion, right? In this case,
Right.
not medical applications, and we can collaborate very closely with them and you know convert their learnings that are generic for general use and maybe in industries beyond healthcare, and actually repurpose those learnings for health impact, in particular pediatric health impact.
That sounds amazing, and really exciting. And so, can you tell us about what do you think are some of the steps that are essential for widespread adoption and acceptance of gamification as a tool in pediatric healthcare, and specifically for developmental disorders?
Trust is key.
Trust.
Privacy, trustworthy approaches are essential for gamification to be successful. You have to trust that it's not immersive and maybe maladaptive,
Okay.
like Fortnite, for example, or something like that. First
Okay.
person shooter games are really interesting to children, but probably not educational.
Right.
Probably, I mean, in hand-eye coordination, certainly, but otherwise not helpful for this particular population. The young child developing differently who needs some course correction does not need Fortnite. They need something else. And
Or a game like Fortnite,
or
right?
a
Just
game night Fortnite, I should say, sorry. Would I let my kids play it? That's okay every once in a while, but after a while we have to turn it off and do something different. So trust of the game itself being something that's supportive and educational
right.
is key. But the child has to trust it too. The child needs to want to play it. Here, trust takes the form of desire, motivation. How do you engage the child enough at enough frequency, enough within one moment in time, but across time, so that they will play at a level that's going to guarantee that they receive the dose that we hope to give them, the dose of training and education intervention that we know will be important for that child at that specific moment in time. So it's that has to be part of it as well. And we can do that. In fact, we've done this in a lot of different ways, not just by inventing in a vacuum by empirical data and knowing generally through research what's likely to be engaging for a child, but by actually co-designing with the children, by
Yeah.
sitting down with them and having them participate in that process. What should be here? What should we call this thing? The reason why we called the Autism Glass program the superpower program was because the kids called it that. They
Huh.
unanimously concluded it must be called the superpower game because when we put on the glasses, we feel like we're gaining a superpower.
That's so
So
cool.
that's a part of it, And then if you're sharing video, which many do, which we're grateful for, thank you for that. The family, the mom, the dad, whatever, the primary care provider needs to feel like this share is valuable. And how do you make that happen? Well, you create a relationship through the game being useful and them knowing that their share is going to support the next family's need. And and with that trust bridge, you can accelerate the pace and volume at which you're going to get shares from your participants.
I love that. Trust is very important, and appreciate how you discuss the role of the parent as well in this. And I think that's why pediatric healthcare and designing for children is so interesting because it's not just working directly with the child, but also engaging the parent in that kind of a collaborative trust arrangement with everyone focused on the improvement and well-being of the child. And love your approach of having the children involved in the innovation, naming it and developing it so that they are going to be really truly engaged and not just thinking about what they need and giving it to them. So I'm sure they appreciate that as well. And I think that's approach many innovators are taking, like with the kind of agile process and software development, really getting kind of the customer involved first so you don't have those reworks at the end. I think that's amazing. I think we're getting close to end of time, but I'd love to hear any closing comments you'd like to make to our audience today.
Okay. Well, one thing I didn't stress, but this may be longer than a closing comment could be or should
Totally
be.
fine.
These gamified approaches create the opportunity for a closed system, a feedback loop through which you can deliver care and capture data as you go.
Okay.
And those data become the source of progression, the outcome measures, essentially the trackers to tell you whether it's you, the game that's completely now isolated and artificially intelligent, that there's proper progression and therefore you can advance the complexity of the game or not, and therefore you can add other challenges that help the child become more proficient with a specific skill you're trying to address. So these games, for the first time in medicine, thinking specifically about medicine in general, a lot of the information that goes into a decision that's reported in a clinical note or an electronic medical record is lost. It's not captured. It's completely evaporated. It's like gone forever. It's in the mind of the doctor who did it, and empirically they may possess the information somewhere in their brain, but it's not recorded and can't be reused. Here we have the opportunity to capture that information and reuse it, build an ecosystem of data that drives future innovations that ensure the game is properly designed and properly personalized and reactive to that individual child's needs. So that's one thing I just wanted to stress, is that as as I say this to my students, I say this to the population who might be listening to this podcast, this is an amazing opportunity to create and invent new things that are really going to be driving future innovations as you create yours. So it's this snowball potential to create gamified approaches that do become medical devices that have this internal calibrator because of the data you collect, and that calibration system can be tuned and changed and personalized in ways that medicine can't do today. So encourage people to be thinking along those lines and thinking about how to bring these things to practice. period.
So, Dennis, would you like to make any additional comments before we close?
Yes, another closing remark is that when you think of developmental health, especially in this young age window from 18 to 72 months, health and education are essentially the same thing. And that's why we can suddenly begin to collaborate and bring educators who focus on pre-K and K through 12 programs. We can bring these individuals who are in the classrooms and delivering educational experiences for children into this invention, into into the creation of these kinds of solutions that will at once educate and treat the developmental needs of a child, which is one of the most important things we must treat. We need to know we need to know where that child is cognitively, and go and meet them where they're at and give them what they need so that they gather the skills to thrive. And with those skills, progress to a point where they can choose their own adventures in life by the time they're 6. So education and health are identical in these early windows of development.
That is really compelling and really kind of makes you think about how healthcare and education can kind of merge and form around that whole child, care, right? In those early years, as you're saying. I find that extremely compelling and exciting. And I know your words will motivate those who are listening into innovating in this way with education and healthcare. So thank you for making that final point, Dennis.
Yes, put the healthcare dollars towards pediatrics and early education, early health, because healthy kids lead to healthy adults.
Well said. Thank you so much. Love having you here today, and look forward to speaking to you again soon.
Likewise, thank you so much for having me.
Thank you.